is really all of our regional partners, primarily our hospital partners, but also our OHP partners, the Ontario health teams, and individual physicians or interested parties. So all are welcome. Next slide. And today we're going to try to just provide you with a snapshot of what's going on in our region, particularly when it comes to the FIT program, some updates with QBP funding, and then we'd like to allow a little bit of time, if possible, at the end for discussion in terms of what's going on in our region, what things we can do to make things better. One of the issues that's been brought up to the program has been the FIT volume. So a lot of our hospital volumes are not meeting what we had projected, and perhaps we can have a little bit of time for discussion at the end in terms of strategies to both improve screening rates as well as to improve the use and perhaps expansion of our navigation programs. So I'm gonna start off just welcoming everyone here. I know everyone has busy days and a lot of other things to do, so we appreciate you taking the time to chat with us today. Next slide. I'm just going to start a little bit with some housekeeping issues with the FIT program. Next slide. So just to start, I'm sure a lot of people on the call know Christine. Christine Stojos is on a mat leave now. So if you try to email her, you'll get a bounce. Her replacement's Barbara Ann Meyer. I'll leave that up on the screen in case you want to just screenshot that. So you can contact her directly if you have any inquiries. The other general screening mailbox you can always reach at cancerscreening@ontariohealth.ca as well for general inquiries. The other thing I wanted to mention, and we've been asked to share to our regional partners, is that if there are any promotional events that anyone's doing in the region, either at their hospital or their Ontario health team, anything regarding screening, any of the 4 provincial screening programs, you can reach out to Ontario Health CCO. They do send out periodic newsletters, so if you're having any promotional events regarding screening, they are happy to include that as part of their quarterly newsletters. Next slide. So I wish I was able to share a little bit more, but I'll tell you what I'm allowed to tell you. The FIT program is going to go through a bit of an overhaul next year. So the current contract is with Life Labs, and it's up for renewal in summer of 2026. So the RFP is currently out. It has not been decided on. But as part of the RFP, the program is looking for enhancements and improvements. And we can share some of those when they're available, but I can perhaps share some of the areas that are being looked at are trying to make things easier for primary care. I think there's been a lot of primary care feedback in terms of some frustrations with the program. They're considering incorporating high-risk screening into the program, perhaps somehow, improvements in communication, correspondence, looking at the threshold for what a positive test is, as well as looking at the age when we start screening. So all of that will be coming soon. I was kind of hoping that it might be available now, but probably I would assume probably by fall or early next year, we should be able to more broadly announce all the changes that we'll be seeing in 2026. Next slide. So I'm just going to do just a quick recap in what's going on with screening in our region and the province. Next slide. So we've been doing colon cancer screening for a long time, and we implemented the FIT program in 2019. And the overarching goals are to try to get a high participation rate, try to screen as many eligible Ontarians as possible. The other major goals are to try to be efficient and not have wasted tests, both in terms of being done inappropriately, as well as kits not being returned or being marked as unsatisfactory. Next slide. One of the elements that's going to be changing is the concept of due for screening. So, unlike other screening programs where they look at percentage of eligible patients screened, in colorectal cancer screening, it was an inverse indicator where people that were overdue for screening. And you're classified as overdue for screening is if you didn't have a fit test in 2 years or more, haven't had a colonoscopy within 10 years, or had a colonoscopy with findings not considered to be as screen relevant. But the plan going forward, and it hasn't appeared on our QPRs yet, but it would be to align this indicator with the other screening programs. So there will be a change in some of the QPRs. I'm not sure if it's going to be next quarter or later this year, but it will change to percentage screened. The other thing that's changing in that category is that the bar is being raised. So right now we're aiming to get 60% of our eligible patients screened. That's going to be raised to 65%. So the program is trying to push us forward in terms of our performance. Next slide. And speaking of performance, we've done pretty well in our region. One of the things that lags not only in colorectal cancer screening, but I think across our screening portfolios is our screening performance. We've got a very large, rapidly growing population. We have certain segments of our population that are underscreened or hard to screen for a variety of factors. And you can see in orange is Central West, and in blue is Ontario. And you can see how we're kind of lagging the provincial average. It's not by a great degree, but we aren't doing as well in our region as they are provincially. The other interesting thing you can see is that dotted line. That dotted line's been moved down ever so slightly, so the bar has been raised. So we're lagging province, and we've got further to go. So that's been a major focus, I think, for the regional cancer program, for a lot of our Ontario health teams, and some collaboration between those two groups, as well as some of our community partners trying to improve screening. The focus of this talk is colorectal cancer screening, but I think we're all trying to get screening improved in general. Next slide. Well, one question that comes up and has come up from several of our hospital partners is, why are we not seeing more fit cases at our hospital? So if you look, and I apologize, there's a little bit of a time lag, but this was the most recent numbers that I could get. But if you look at percentage change, 24 to 23, 24 to 2019, overall, it seems like we're growing the number of kits being sent in the province. Like if you look at April, we've gone from like maybe 50 or 60,000 to 70 to 80,000. So it looks like we're doing a pretty good job in doing tests in the province. What does it look like in our region? If you can go to the next slide. In our region, it looks pretty similar. It looks like pretty healthy 20% plus growth rates in terms of our fit test collection. So that kind of begs the question, where are those fit cases being done? I don't have that answer. We have put a request in to try to sort out what percentage of the fit positives are being done by our organized screening programs versus elsewhere. And that's something we'll keep you up to date on. But it doesn't look like the number of fit cases is the major issue in terms of the volumes we're seeing at our programs. Next slide. The other slide that I put up here is colorectal cancer. I think a lot of you lived through the pandemic and were on a lot of these Zoom calls during the pandemic. And one of the concerns when everything came to a halt in terms of screening in 2020 was that eventually we were going to see a very large number of advanced cancers. And again, there's a lot of time lags, particularly with colorectal cancer cases in terms of coding and such. But to date, we have not seen a spike in late cancer. So it's been quite a few years. We'll see if there's a late spike, but so far it's not something that we've seen, even though there's still a little bit of concern that that may not be the end of the story yet. Next slide. So that's the update on FIT. We'll circle back to the FIT programs and the screening performance and perhaps some regional initiatives that we can do to improve our numbers at the end. But I just wanted to go through our regional report cards, the quality metrics, and some QBP issues next. I see a comment in the chat, and perhaps Crystal, you can kind of keep track of those, and we can address them after we go through these numbers. So I apologize again. If anyone is from a hospital or a clinic, you get these report cards once a year. This is not the report card of any particular facility. This is the report card for our region, and you'll see it's release year 24. So this is data up to March 31st, 2024. So there's always time lags. It's usually published at the end of the calendar year. So this came out December, January, this winter. And just to show you some highlights, the top four bars, our region does as well or better than province in some quality indicators like adenoma detection rate and polypectomy rates. The area that perhaps we're not doing as well is in our wait times, and that's I don't think a surprise to a lot of people on the call. The indicator should be in the blue, and you can see our regional cancer program in terms of the wait times is just a little bit off of province. And again, this is just on block. I think some facilities are doing better with their wait times than others, but in general, we are lagging provincial average by a little bit. Next slide. The other performance metrics in terms of complication rates like perforation, bleeding, post-colonoscopy, colon cancer, our region is doing fine. It doesn't seem like we are much different than the rest of the province. So there are no concerns in terms of our technical performance of the colonoscopies as a whole. Next slide. And the wait times, again, we are 1, 2, 3, 4, 5, 6, about 6 down. 53 days was our 80th percentile wait time. So we're just in target as a region. But again, we're probably kind of middle of the road or middle of the pack in terms of the province. Next slide. Just to give everyone a little bit of perspective, and I apologize if I've shown the slide before, but I show it almost every event, but this is where we were before the FIT program in 2019. At that time, the Central West region and the Mississauga-Halton regions had their own separate reports, and it's always the easiest to find. Just look for the two worst, and it's our two regions. So, the two worst performing, 92 days and 84 days, Central West, Mississauga-Halton. So that was 2019 when we were the two worst regions or the one worst region in the province. 2024, 25, now we are maybe a little bit below average in overall screening rates, but we're fairly mid-pack for a lot of the indicators, or just slightly behind. So although maybe there's still room for improvement, we certainly have made big strides over the last 6 years of our programs, thanks to probably everyone on the call here today. Next slide. The other thing I just wanted to point out, like, I think we all chase numbers, but there's a reason why these numbers are there. So I just wanted to put that wait time number in perspective. So when someone has a positive FIT test, if they're diagnosed late, their cancers are upstaged. So it seems like the biggest difference is if it goes more than 6 months. But certainly, yeah, the sooner, the better. I'm just getting a little bit of feedback. I'm not sure if that's on my end.
Yep, sorry, just muted that participant.
Oh, okay.
We should be
Okay.
good now.
We should be good. Okay, I wasn't sure if it was something with my mic. Yeah, so the big thing. So there's two take homes from this. Obviously, we wanted to get people done sooner because they have a high risk of cancer. There's another indicator that looks at people that go more than 6 months because that's the really tragic one that where you identify a problem and then you had an opportunity to make a big difference and then perhaps you can't make that big difference anymore. So though that factors into two of the indicators. And I'll talk to you about that in a second. Next slide. I think yeah. So this was the more than 6 month indicator. This used to be reported more routinely on the QPRs, but we made a big dent in it. It was up to about 20%. That sounds really high, but 20% of people with a positive FIT test were not getting colonoscopies. And they had, fairly high cancer rates. When they were diagnosed, they were often late stage. So you can see there that back in 2019, 2020, the numbers were around 20%. They've come down. They're still just under 10%, high single digits, which is still too high. But it seems like because there's been such a dramatic improvement, it's not really as much of a focus. It was more of a focus when they were high. So that's been a big win for the program. Next slide. And these are our numbers. And again, it looks like this is ancient history, but there's some big time delays in terms of getting these numbers. So they're several years late. But our provincial program, we're running around 5%. So if you have a patient that comes into your program or comes into your office or comes into your institution with a positive FIT test in Ontario today, you can tell them based on our data, you have about a 5% chance of having colon cancer. So, that's a very high number. In perspective, if someone has a symptom like rectal bleeding, change of bowel pattern, the things that we refer people for, they have a less than 2% chance of having colon cancer. So it's a very high yield indication, a very important indication. And that's why there's so much focus of the program in terms of making sure these patients are seen in a expedited fashion and get their colonoscopies done within wait time target. Next slide. I think that's a duplicate slide. I think I forgot that. Oh, quality reports. So we went through the regional quality reports, but people on this call may have gotten other types of quality reports. There are facility quality reports, and then there are individual reports if you're an endoscopist performing colonoscopy in this province. So what's new? A couple of things for the endoscopists that may be on the call. In the past, if you had a complication, a perforation, bleeds after colonoscopy, a post-colonoscopy colon cancer, you would get notified on your report card. They would give you the health card number so you could review the case for your own quality improvement and feedback. But the problem on this year's reports is a potential privacy issue has been identified. So those reports that went out late last year do not have those numbers. There's no way of getting those cases. So I apologize for the program. It's out of our hands. We are meeting with the privacy officer in the province to try to work towards a solution and a workaround, hopefully for next year's round of report cards. The other thing that's new I had mentioned is the bars are being raised. So the wait time bar is being raised, not in terms of the actual number of days. 56 days is still the wait time, but instead of getting 80% of people in that wait time, it's going to be up to 85%. So again, a little bit more challenging to get people in on time. We want to get more people in on time. And the overdue for screening or percent being screened, we want to go from 60% being screened to 65% being screened as our new, more aggressive targets as we are making improvements. Um, there are some other changes I won't get into on post-colonoscopy colorectal cancer flagging. We have a program called facilitated feedback where if there are issues raised on someone's individual report card in terms of complications or post-colonoscopy colon cancers, that they're identified for a conversation, purely a quality improvement. It's not a college review or a punitive review. It's just really for quality improvement. So there's some changes in the methodology that's probably beyond this particular audience. But if anyone's interested, you can contact me and I can send that to you. The other thing that's new again for the endoscopists, and it's the marker of focus this year since we don't have individual case level data to review for identified individuals, is adenoma detection rates less than 26%. And again, just briefly, this has been identified as a marker of risk. So if individual endoscopists have a lower than 26% adenoma detection rate, they tend to have poorer outcomes, more post-colonoscopy colon cancers. And there is some evidence that intervening in this group and with education and quality improvement can reverse some of those bad outcomes. So some people on this call, if any endoscopists are on, if you get a call from me or another regional lead to discuss your report card, it's probably because of the ADR. So that's something that's going to be a new focus for individual endoscopists. Next slide. Yeah, so we talked about the wait time indicator. I kind of got ahead of myself, but yeah, so we're going to be moving up from 80th percentile to 85th percentile. So I won't belabor that. Next slide. The other thing I wanted to mention, particularly for the hospital partners here, is when we calculate or when Provincial calculates wait times, they exclude certain denominators. So if someone has a fecal test in an inpatient setting, that's not counted. If there is a patient self-delay, then for the hospital in the region, that does not affect your wait time performance. So I know a lot of us are concerned about our wait time performance and are trying to improve it. So if there are patient self delays, so if someone's offered a colonoscopy next week and they say, "Listen, I'm out of country, I can't come for 2 months," that person should be coded as a patient self-delay when they're being booked by the whoever's booking that case, and that case it still counts as a fit case for your facility. You still get paid as a facility, but that wait time is excluded from the calculation, so it doesn't affect your wait time if it's a patient self delay. I don't think any of the hospitals here are so small that they have less than 10 colonoscopies per quarter. So, um, yeah, we'll just move along. Next slide. The other thing I want to talk about is something that's come up in the hospital report cards. Next slide. There are two things that they mention, and they don't mention them as mandatory, but in my experience, once OHCCO starts to mention things, they are looking for these things. So, and we ran into the situation, just to give you an example, before where they started to mention for several reporting periods that they're looking at the number of average risk colonoscopies per facility. They started mentioning that. They started mentioning, we'd like it under a certain percentage. And then all of a sudden, they started penalizing and cutting funding for facilities that perhaps weren't at that target. So I've kind of seen this play out before. So I'm just giving this as a warning, particularly for our hospital partners, that these are probably things that OHCCO is interested in. Right now, it's just interest, but it may you never know, down the road it may impact funding or growth. And those two things are patient experience. And I think that's one thing that I've always kind of been chatting at our provincial level, that we kind of lag some of the other programs is getting good patient experience data. So they're asking hospitals to consider starting to collect some data on patient experience, and they'd like to see, now that most of our hospital partners have established fit programs that are running well, to consider expanding those fit programs to centralized referral programs to help reduce wait times for symptomatic cases or other targeted cases of concern. So I just mentioned that to the group, just for your awareness, and certainly I think if you're able to do these things, it probably would be looked upon favorably when we get to the next section in terms of QBP. Next slide. QBP. So, couple of updates. We all know that we go through this funding cycle. There's a initial allocations. There's a request for in-year funding adjustments, and those have kind of gone through. And then there's the year-over-year growth. And the reason I put this slide up is to remind me to mention that one thing that's new is when you submit requests for growth, um, we are now being asked as a region to sign off and comment on it, um, to help us help you. So we're always happy to support required cases. It helps us to understand why you're asking for cases. So if you have a small 3% volume growth in general, that's probably not something that you need to call me or the program about to discuss. But if you want to start a new endoscopic ultrasound program or have a big some new technology, ESD, Axios, Barrett's treatment, some major change in your program, it's probably going to be useful to bring that up with myself and with the regional cancer program, just so we can kind of better understand it and hopefully better support you in that application. Next slide. The other thing of interest that I hope I'm able to tell you, because I've got it on my slides, but they are going to be looking at funding for some of the more advanced therapeutic cases that a lot of our hospitals are doing. These include endoscopic ultrasound, which is already being funded, but perhaps expansions. Some other technologies like Axios, cholangioscopy, POEM, which is per-oral endoscopic myotomy, RFA for Barrett's, ESD, which is endoscopic submucosal dissection, currently kind of being lumped in with EMRs. But they're going to convene at some point working groups and try to get costing. So stay tuned, particularly the facilities that have large therapeutic programs. Hopefully there will be specific funding for some of these expensive procedures that we're doing now. So hopefully this will help with everyone's budgets going forward. Next slide. Um, the other thing I want to mention is about allocation. The stated objectives of the program are to support, provincial health system, and I think the word recovery is post-COVID. They were trying to align allocations with actual performance, and as opposed to just expected facility performance. And there's probably going to be some realignment in terms of the fit positive cases being funded where they're being done. Next slide. Um, I again apologize for the formatting of the slide, but the take home from this slide is that ERCP with intervention and fit cases do not require pre-approval. So if you overperform on either of these indicators, they're automatically approved. So you don't have to worry about them not being funded. You don't have to ask OHCCO, we're doing 500 more fit cases than was allocated. They're automatically funded. They're automatically approved. You don't have to worry. You can do as many as need be. So that's kind of nice, and I think that's a recognition that these fit cases are priority cases, and most ERCPs with intervention are necessary cases. So they've kind of removed the barrier of having to beg to do more cases if you're seeing more at your facility. Next slide. This I copied and pasted, and what I wanted to highlight is in the brackets, prioritizing high yield over low yield colonoscopies, supporting equitable access to GI endoscopy procedures within and across regions. So these are some of the factors that they consider when you're applying for additional funding, either incremental volumes or new volumes or new specific procedures. So it certainly it improves the strength of your application if you are doing these. So and they're specifically looking to see programs trying to actively decrease the level of their average risk screening being done at their hospitals, and anything that we're doing and a lot of the work that we do together as a region to try to support equitable access to care and to screening. These are all seen very favorably when we make our applications. Next slide. The last thing, and I've been talking a lot, and I do want to leave some time for discussion, that I wanted to mention is EHR. So I know a couple of our large hospital partners already have transitioned, and one of our large hospital partners is about to transition to a electronic health record. And the facilities that have transitioned, I do not have to tell them that there are some issues with coding and data entry. So I think that's recognized. From what I understand, some of these issues involve data entry into the system by the staff, and some relate to the ministry's ability to pull data from some of these electronic health systems. So what I've been asked from provincial to let our hospital partners know is that early on, facilities that are undergoing transition or in the process of transition to an electronic health record system like Meditech Expanse or Epic, let Ontario Health know early so they can proactively monitor data quality, and if there are queries, they can assist in terms of trying to get things up and running as quickly as possible. I know one of our hospital partners went kind of dark with all their data for several months, which was caused a little bit of angst for all parties. So if you are going, I think Ontario Health would like to know early so that they're aware of it, and they can help liaison with your EHR provider to try to address any data issues earlier. Next slide. So I've kind of dominated this, and I did want to present some of those issues, but I did want to allow a little bit of time for feedback and discussion. Next slide. Some of the issues that have come up were, in terms of what kind of engagements we'd like to do, and what are some of the strategies that we could do to increase screening in general, and in particular colorectal cancer screening awareness, as well as awareness of our fit programs. I'll just pause here, and if anyone, maybe you could just raise your hand if you'd like to comment. While we're waiting, I'm just looking at at the chat, and I see Dr. Bedan chatted about or queried about posters in cultural centers, and I think Crystal had replied that we are doing some engagements in that group. We've reached out and worked with the Olive Branch of Hope. We've been to some religious centers and done some promotion. We also have outreach with some of our community health organizations, and we have a community ambassador program to try to assist in some of these underserviced segments of our population. Dr. Axler always astute and asks me a question that I can't answer, but I think that is certainly being looked at. If I wasn't being recorded, Jeff, I might be able to give you more. But I think that is something we're not supposed to announce it, but I think they are looking at that start age. That's about as much as I can say. Is anyone here from primary care involved in primary care CME at their facility, hospital on the call? Because one of the things we were wondering at the Regional Cancer Program is perhaps um, if there were primary care rounds at the hospitals. I know some of the hospital partners do have those. If that would be some opportunity there to have presentations on our screening program. So not only on screening, but on our screening programs and what they can offer. The other thing I should promote is our website that just launched. And Crystal, if you're able to put maybe the link to our website in the chat, that might be nice just so people can take a look. There's a lot of great resources. They've done a lot of work on it. I think it's something that can be useful. The one thing that's not on the website yet is referral forms, but I think we'd like to have our organized referral programs for FIT have their referral forms and fax numbers on there. So it's a one-stop shop for any primary care in the region that they can get access to those. Thank you, Crystal. You're very fast. Do any of the hospitals have any comments in terms of their challenges, in terms of their particularly with their FIT programs, in terms of volumes? Oh, I see someone with a hand. Go ahead.
Hi, Dr. Bellini. I'm Anina, the manager.
I just saw AS. I wasn't sure who AS was. Hi, Anina.
It's me. Anina Skemper. I'm the manager at the Trillium Health Partners Endoscopy Clinics. I know we discussed this before, but I think maybe if some people can have some insights and share with me, that would be great. A friend of mine had received a letter from Cancer Care Ontario stating that they should get a FIT colonoscopy test. They are due for it, which is great. I didn't know that those were being sent out yet. The problem is at the bottom of the letter, it said, you are due for colon cancer screening, but you can either opt for a colonoscopy or for a FIT test, which was very surprising to me. That's my one comment. And then going back a little bit through to something you discussed earlier in the meeting, looking at where patients go for their colonoscopies, if those tests come positive back to the physicians, I think if we have a way of directing patients to primary care hospitals or clinics, that would sort of guide us to know where they are going, because I think what's currently happening is patients go wherever they please.
Yeah. So thanks for those comments, and those are not unique comments, and they are comments that have been heard by the program. The first comment's a little bit different, though, and if you have a copy of that letter, you can blank out any patient identifiers if you can send it to me, because I did not think that usually Cancer Care Ontario is very careful to word their letters very carefully. So I wasn't aware that they offered average risk colon cancer screening on the letter. That's somewhat surprising to me. But so if you have a copy as to the wording, I wouldn't mind taking a look at that, and I could certainly forward that up
I
the
wish
channel.
I wish I could, but she
Oh.
already threw it out at the
She threw,
time when we were
oh
talking.
shit.
Yeah, so
The other thing I can do is let me write myself a note is I can ask for a copy of that letter, the 50-year-old screening letter. I can see if I can get that copy just to see what the exact wording of that is. Um, the other issue has come up more often from primary care. So one of the issues primary care would like to see is like an automatic referral program. And just to give an example, with the breast screening program, you get sent in for a mammogram. If there is an abnormality that's suspicious, you don't have to go back to your family doctor, get a request for a biopsy or an ultrasound or whatever you need. It just gets done and it's signed off on. It's considered an automated referral. And one of the things our primary care leads have been petitioning Ontario Health CCO is can we have it as if I order a fit test, if it's positive, it automatically gets referred to our local fit funded fit centralized referral program. So all I can tell you is that message has been conveyed, that message has been heard. From what I understand, it is probably not on the table for this round of improvements that are coming next summer. And because of that, one of the things we were thinking of as a program and in conjunction with our primary care leads is to try to promote our programs a little bit more aggressively. I think we've done a good job promoting fit. We've done a pretty good job promoting fit screening. We're still working on some hard to screen groups, but I think the next step is to try to funnel those cases into our programs that are being funded to do these cases. So I think that's something that we're going to be working on. That's something we'll probably be kind of tapping some of you on the shoulder for as well. I was kind of hoping that perhaps maybe some primary care would be um, on the line, but we're going to circle through our primary care leads with our with our regional partners and with the primary care networks to try to do some dedicated promotion of our organized referral programs. But yeah, I think the idea of a automated referral is a really nice one, but I think it's just it's a little bit more technically challenging for the program to pull that off. So I'm not really anticipating that to be part of the package. Um, Maybe I'll be surprised, but I don't think that's going to be part of the package next summer.
I'll go again, not to monopolize the meeting,
No,
but
no, no, no. You've got the floor. Everyone else is shy.
my next question, just for some clarification, if you don't mind,
Yeah.
is at some point I may have either misunderstood or misheard, but
Okay.
I thought that there was a direction from CCO to go with fit cases to be primarily done in like a hospital setting and funding to be associated to those hospitals. But we find that patients are still, like I say, going to outpatient clinics and whatnot
Yeah.
outside of hospital setting.
Yeah.
Is there a confusion on my end, or is it something that's
No.
in the works?
So it's a confusing area, but there's no confusion on your end. You're probably absolutely right. So here's the thing. So fit cases are only funded in hospitals. Um, and they can be done out of hospital, but the facility receives no funding. So the program has no way of stopping people for doing things for free, right? So if the hospital does the case, they get paid whatever the QBP rate is. If a clinic does the case, they get paid $0 for doing that case for being a fit case. So it's something that's a little bit hard to police. So it's promoted, but it's not policed. So that's kind of the situation. What I don't know, and what we've requested, and I have not seen the answer yet, is if we can get a breakdown, particularly for our region, of what percentage of fit cases in our region are being done in hospital versus out of hospital. And I'm just thinking now in one of there's one of the report cards that you can play with and go by region. I don't know if you can do it by fit, but I may after I get off this call try to see if I can find it. But it's not something I've seen before, and it's not something that's really been presented by the program before. And if I can't figure it out, hopefully Provincial can give us those numbers, because I think that would help us at least be aware of the magnitude of the issue. If you know if 60% of the fit cases are being done outside the organized screening program, that's a big issue, and there's probably a lot of room for improvement. If it's 15-20% being done, it's still an issue, but that may be a more difficult practice pattern to change. So I think it would be useful to know that data. So like I said, when I get off the phone or get off the computer, the Teams meeting, I don't think I'll be able to find it on those those monthly reports that you can identify. I just wonder if you can do it by indication. I don't think you can, but if I can, I'll let you know. Are there any other comments, concerns? I see a thumbs up. I think everyone's anxious to get back to their days. And if there's no other questions, I'll give you all 10 minutes back. Please feel free to reach out. You have my email. You've got the Regional Cancer Program's email. Any questions, queries, we're here to help. And going forward, probably through the summer into the fall, we may be tapping some of you on the shoulder in terms of trying to work together for some of our educational programs and our promotional programs for our programs. Great. All right. Well, thanks everyone. Thanks, Crystal, for putting up the website again. You can bookmark that. It's only going to get better. Right. Thanks, everyone. Crystal, I'll stay on the line after and just to chat.
Sure, sounds great.
Thank you.
Oh, you're very welcome. Thanks, everyone, for taking the time.